artificial intelligence in order to help clinicians, ICU clinicians, to devote their time in the ICU for their critically ill patients. So let's start just to understand the motivation for CLEW by taking a look at this patient, a 75-year-old patient that was admitted to the ICU due to pneumonia, severe pneumonia after a surgery. On the morning of day 2, he started to feel a bit worse. He had a minor trend up with his heart rate and temperature, but we can overall say that he is still stable. And even though that he was continuously monitored, by 10 p.m. In the same day, he was already in septic shock. And despite treatments, he still continued to deteriorate and eventually needed support, both ventilator and administration of vasopressors. So this patient could, in his state, died, but he luckily made it. However, there are penalties for this kind of stay. The first thing is that he was hospitalized for over 2 months in the ICU. And the second and third things that he suffered from both brain damage and major motor disability for the rest of his life. So, given all that, we can come up with 2 important conclusions. The one is that early prevention and early intervention can help patients in the ICU have better outcomes. And the second one is that for this kind of problems, big data analytics can be the next generation solution, we can call it, because ICU physicians can monitor all patients all the time, and even if they could do it in an utopic world, they can't have access to all the data for every patient in every time frame. So this comes up to CLEW Medical, a company that was founded in 2015. And the purpose was to use big data in order to predict the clinical course of patients in the ICU. We had a Series B recruitment this year recently, and we also started from the ICU and tele-ICU, but this platform may be implemented in the future, in the near future, in actually all sorts of health settings. We work with, you can see, several hospitals from all over the world's leading healthcares, and already proven successful in the ICU setting. We have 2 sites in deployment in the United States. And for the past several years, we focused mainly on creating models for patient deterioration. And in some point, we got to the understanding that it's not only important to say which patient is going to deteriorate or need extra care, extra time, but also say and predict who are the patients that are not going to need any intervention at all for a substantial period in the ICU. And by doing that, we can help the clinicians to focus on the more critical patients, more unstable patients, so the benefit will be big. So the goal of our model was to predict whether a patient will require a major intervention in the upcoming 12 hours. Major intervention may include stuff like intubation, vasopressors administration, or CPR, for example. And we chose the 12 hours prediction to be more like a shift time for the time shifts in the ICU. In terms of model development, the study included all the stays and the admissions of patients in the UMass Memorial Medical Center between July 2006 and September 2017. And we got all the raw data that was very unique, a lot of data, including vitals, meds, labs, flow sheets, admission data. And in order to enrich this data for creating the model, we did 2 important things. So one thing is adding the clinical knowledge that is actually a layer that helps us enrich the features, like calculating mean arterial pressure or adding indexes like SOFA or shock index. And the other thing is to add the time series functions, which we can say are like minimum, maximum trends of features and other mathematical operations of the data. So eventually we came up with 904 features that are approximately 1 million samples of data. So after validating and testing our model, these are the results. You can see the number of patients over time. The red patients are the patients that are currently undergoing intervention. The yellow patients, you can see between, are the patients that will go an intervention in the upcoming 12 hours. And as you can see, the green one are almost a third of the patients that will not require any intervention, any major intervention in the upcoming 12 hours. For a clinician in the ICU, it's a challenge to say who are the patients in this group. So our model achieves a sensitivity of 66% with a specificity of 88%. And there is always a trade-off when talking about a model between the sensitivity and specificity. So depends, of course, on the threshold we choose. So one important requirement we had from this type of model is that we wanted to minimize the false positive as much as we can, because unlike the deterioration models, here a false positive means a much more crucial effect on the patient. As you can understand, if I'm saying that this patient is stable and not going to deteriorate or require extra care for the next 12 hours, but eventually he did, so this is a situation we don't want to get. So we wanted the specificity to be high as much as we wanted. And the right graph can also, you can see the sensitivity. As the sensitivity increases, actually, we get more true positives, which mean the percent of correctly predicted intervention-free shifts. But the price for that we need to pay is the decrease in specificity, which are two different ways of showing it. And so again, you can see the result, but this time with the black line that represents our model, that predicted over 60% of episodes where patients did not require any intervention. And if we are applying this on the ICU, we can say overall that 20% of patients will not need extra care in a specific time and could be also monitored as low-risk patients or marked as low-risk patients, allowing the physicians to devote their time to more critical care patients in the ICU. Here you can take a look at a real-time unit view. This is our ICU monitor from lab environment. This one specifically is from the cardiac ICU at the Memorial ICU in UMass Hospital. All the data is real, except of course for the names, which are de-identified. And you can see that the patients are sorted according to predicted risk. In the green are the patients that will not require any intervention, the model we discussed. And in the red, there are patients that already have alerts in the system based on the deterioration models, which is for a different presentation. And that's all basically. Thank you very much.